Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order. I think this will be very convenient for the continuous study. Now in the last three classes we have explained the basic part of the DMD or muscular dystrophies. Then comes the genetic etiology and pathology. In the last class we have explained the clinical symptoms. Now in this class, probably the last class related to this particular muscular dystrophies, that is lab investigation and treatment. The lab investigations, the most commonly is serum creatinine phosphokinase. Okay, CPK, it is also called a CPK level. Serum creatinine phosphokinase level are consistently elevated in a DMD, even in the pre-symptomatic cases also. So looking at CPK level, although there is any symptoms, if you have got a strong suspicion, you can go for a CPK level to identify this. Of course, CPK will go into increase in many conditions. So many other muscle problems also CPK will go into rise. Okay, just like alkaline phosphatase, the CPK can even also rise because this in so many other muscle problems and thyroid problems, parathyroid problems, etc. But this is a guideline. Okay, so if you want to identify at the earliest, serum creatinine phosphokinase level are consistently elevated in DMD in pre-symptomatic and symptomatic level. Usually the serum CPK is 1500 to 35,000 international units per liter in affected cases. What is the normal level? The normal level is less than 160 international units per liter. CPK level should not go beyond 160 per liter. But abnormal CPK level may reach up to 1500 to 35,000, which is very high. Okay, so now this is incompatible with the diagnosis of the DMD. Although in the terminal stage, now we have to understand why CPK is considered as the most important diagnostic investigation. The reason is, see, muscle is there. So muscles are made up of proteins. Muscle protein. So one of the most common muscle protein is creatine. Okay. Now when muscle undergo degeneration, the creatine is get released into the blood. Creatine muscle protein get released into the blood. Now this creatine which is released into the blood will be reabsorbed into the system. Okay, body don't want to waste it. So if it has to be get reabsorbed, that creatine has to be get converted into creatinine. This conversion of this creatine into creatinine is only possible in the presence of a creatinine phosphokinase enzyme. Suppose if the muscle is undergoing wasting and more creatine is coming out, in order to reabsorb that creatine, so body will convert it into creatinine by the help of a creatinine phosphokinase enzyme. So in the blood, creatinine phosphokinase level enzyme will go into rise. So when this creatine phosphokinase enzyme is abnormally raising, it suggests that more and more creatine is releasing from the muscle. It may be because of degeneration, it is released into the blood from the muscle. So this gives a clue that yes, something is bad is going on in the muscle because more creatine is coming out. That means muscle is undergoing degeneration. So this is how CPK is used. One more test, that is CPK-MB. This is very specific for cardiac smooth muscles because in the cardiac smooth muscle also dystrophin is present. If the cardiac smooth muscle is undergoing degeneration, we have to go for CPK-MB. M stands for myocardium. Okay, CPK-M. So M stands for myocardium. So that gives the idea that whether cardiac smooth muscles are undergoing degeneration because of dystrophin problem or not. Now what happens in the terminal stages of the DMD? Suppose patient is ambulated, it's a chronic now, okay, since last 15 years child is having this problem, treatment is going on, and now you are going for CPK level. You may find abnormally decreased levels of CPK, maybe sometime normal or less than normal also sometime. What it suggests? It suggests that there is no CPK, creatine phosphokinase enzyme in the blood. Why it is not there? Because there is no creatine coming out from the muscle into the blood. Why creatine is not coming out? Because muscle is already undergone degeneration and there is no muscle protein in the name of creatine is present or existing in the muscle. It is already over. Everything is exhausted. Everything is dystrophied. Okay, so therefore in the chronic stages, in the later part, CPK level may be normal. So a normal CPK level should not be considered as a good sign. In a chronic cases, or okay, in a prolonged cases, you may find normal CPK level or decreased CPK level. Okay, so although in the terminal stages of the terminal stage, the CPK level will decrease as the muscle degeneration is over. There are some specific CPK to identify the muscle involved. Just I told CPK-MB, CPK-AA, CPK-SA, etc. They are specific to the myocardium, specific to the skeletal muscles, etc. One more lab investigation which can be done is a cardiac assessment. The cardiac assessment can be done by echocardiography or electrocardiogram, etc., chest X-ray, etc. EMG, electromyogram. It shows the characteristic myopathies. In the first slide also I explained differentiation between myopathy and neuropathy. So it shows the characteristic myopathy changes but not specific to DMD. In general it can say yes, myopathy is going on. There is no evidence of degeneration, motor or sensory nerves motor and sensory nerves are normal and conduction velocity is also normal because EMG is related to the myo means it is related to the nerves. Okay. But some changes will be there. That means myogram in the sense muscular activity is also related to the nerves, isn't it? So EMG gives whether that neuromuscular integration is normal or not. Okay, but muscle biopsy gives the correct picture of a muscular dystrophy. Yes. Now comes the muscle biopsy. Muscle biopsy is always confirmative. Especially we will take biopsy from the vastus lateralis, quadriceps, femoris, gastrocnemius, etc. There may be endomysial connective tissue proliferation and scattered degeneration muscle fibers and segmental necrosis and inflammatory cell exudates which clearly suggest that muscle has undergone degeneration. If the CPK level is increased with the positive family history, suppose, no muscle biopsy is required for the diagnosis. If it is happening for the first time in this kit, it is required. Otherwise, positive family history is there, CPK level is raised. Then itself it is sufficient to go for the diagnosis. There is no need of a muscle biopsy. Nowadays they are also going for the, most commonly they are going for the genetic test. Okay, so particular gene problem is clearly indicating. Most of the muscular dystrophy cases now what we are attending, so they come with a genetic report. Okay, another one is polymerase chain reaction. The specific molecular genetic diagnosis can be done. This is what I am telling. Karyotyping, so they come with the karyotyping report. So defective dystrophic gene by immune histopathological staining of sections of the muscle biopsy tissue or by DNA analysis from the peripheral blood. So this is a confirmatory diagnosis nowadays. Yes, there is one more sign which is called as a Valley sign. One is Goward sign, another one is a Valley sign. Valley sign is also called as Pradhan sign because actually this sign was first demonstrated by an Indian scientist, okay, Pradhan, Dr. Pradhan. So therefore it's also called after its name, Pradhan sign. So in the case of the DMD, the patient is asked to abduct the arms about 90 degree under the flexion of the elbow at 90 degree. Elbow is flexed at 90 degree, okay, elbow is flexed at 90 degree. Then he has to raise the hand. Okay, then he is asked to abduct the arms. So in this position, muscles around the shoulder, scapulae, axilla and upper arms are inspected to get the specific pattern. A linear groove or sometimes a oval depression running obliquely from the spinous process of the scapula to the axilla is seen, and this is due to wasting of the muscles required in the formation of the posterior axillary fold. The muscles which are required for the formation of the posterior axillary fold are undergone wasting. They are undergone wasting, and because of this a linear groove is seen that looks like a valley of the mountain. Okay, so therefore the name Valley sign is given. On the other side of the depression, two prominent spots are visible. So in between there is a depression, so this gives the impression of a valley. Okay, so therefore Valley sign. The inferior medial bulging is due to the hypertrophy of the infraspinatus muscle, and the superior lateral bulging is because of the hypertrophy of the deltoid muscle. So whole appearance is just like a valley between two mountains. Therefore, it is called as valley sign, especially in case of a limb girdle muscular dystrophy. So this sign is quite beneficial, and even in the later stages of the DMD also this valley sign can be seen. Coming to some of the other investigations, we are talking blood serum CPK levels are increased. We know that CPK-MM is very specific, and levels are increased to high range in pre-symptomatic status also. So this portion already we have covered. Now looking at the complications, what are the complications which may be there? Yes, contractures may be there, psychological disturbance, deformities, respiratory insufficiency, cardiomyopathies, cardiac problem, arrhythmias, obesity. Okay, obesity, because the child is not able to move, so he is now ambulated because he is not doing any exercise and movement and all. Obesity is one of the main problems. Talking about the treatment, so there is no proper treatment. Either there is a treatment or cure, or there is any medication for arrest the progression. Therefore, it's a progressive disease. There is no medicine so far available for arrest the progression or as to give the complete cure, because it is basically a genetic problem. Okay, so dystrophin gene responsible for the formation of the dystrophin itself is get affected. So aim of the treatment is only to prevent the complication and to improve the quality of the life. So to prevent the infections, we have to take some of the care, then ambulations, then good nutrition status, then physiotherapy can be done. One of the treatment which is tried is myoblast transfer therapy. Myoblast means in which the normal myoblast, muscle tissues, from the muscle of the genetically close relative, usually father, is cultured in the vitro and injected into the deficient muscles with the expectation that they will form the healthy myofibrils later with the normal dystrophies to replace the degenerating muscles. This has been tried, this effort has been done, myoblast transfer therapy, but results is not encouraging. A similar type of approach can be also done in Ayurveda. If you're talking in Ayurveda, we have the concept of Mamsarasa Prayoga. Okay, Mamsarasa can be given orally, maybe through the burst. We can try for that. Now, some of the other treatment aspects like prednisolone can be tried. Daily prednisolone improves the strength of the muscles in the children with the DMD, and this is only demonstrated treatment of a DMD. In the DMD, usually we will find child is coming to you with the prednisolone treatment when he is coming to Ayurveda. So this prednisolone actually temporarily that increases the strength of the muscles, but it is not basically correcting the core problem. And there is no role of calcium channel blockers, vitamins, etc. It is not a vitamin deficiency disease. Okay, usually in all the muscle weakness we will try with the calcium problem and all. So we will try with the calcium preparations. No, there is no use. Fluoride supplementation can be done if the water is deficient in the fluoride. Maxidol. Maxidol is nothing but a growth hormone inhibitor. This can decrease the degeneration of the muscles to some extent. Not correcting the problem, it decreases the degeneration to some extent. Anticholinergic drugs can be tried. They are the ganglion blocking drugs. That means anticholinergic drugs so should be avoided. They should not be given. Okay. Obesity should be treated. Contracture should be treated, and all the patients require wheelchair eventually one or the other day. Scoliosis, kyphosis should be corrected by instrumentation or surgeries, etc. Treatment should be done to prevent the respiratory and cardiac complications. Now lastly, few words about the BMD. Now BMD is first reported by the Baker and Kenner in 1955, hence the name Becker's muscular dystrophy. Mode of inheritance is almost all same to that of the same of a DMD. It is also X-linked muscular dystrophy. The gene is located at XP21. Onset of the weakness is late. This is slowly, only difference is from the DMD is it is a late onset and slowly progressive, not fast progressive. The onset of the weakness is late, usually after the age of the 7 years and often into the second decade. Ambulation will occur typically at the age of 30 years, whereas see in case of DMD, ambulation occurs in 11 years itself. The rest of the manifestations are very similar to DMD. Only thing is slowly progressive. Quality of the life is quite good here. Patient can survive up to 30 to 40 years. Whereas in case of a DMD, the survival rate of the patient is only up to the second decades. So rest of the manifestations are same. Boys' complaints of pain in the muscle or cramps after the exercise may be the first symptom. A 14-year-old boy complaint of pain and cramps in the muscles after doing some playing activity and all may be the first symptom. Muscle strength is relatively normal, but vigorous exercise produces the pain and cramps. The mental retardation can occur in BMD sometime. Okay, incidence is 3 to 6 in 1 lakh. Incidence is less, 1 lakh. That incidence is about 35,000, 1 in 25,000. These patients are prone to hyperthermia, and CPK level will be between 2,000 to 20,000. Again, quite less compared to DMD. And rest of the investigation and treatment is similar to DMD. So this is Goversign and this is ambulated patients. And now this is all about the treatment aspects of a muscular dystrophy. Two most common muscular dystrophies like DMD and BMD is covered, and there are so many other muscular dystrophies like Emery diffuse muscular dystrophy, myotonic dystrophies, then comes limb girdle muscular dystrophies, shoulder girdle muscular dystrophies, and many other types are there that we are not discussing. Other videos which is present in my playlist related to muscular dystrophies contain detail of all these things. You can refer that. Now this is only a short version of a BMD and DMD which may be quite useful for the PG students or UG students. Thank you very much.